The management of malignant ascites. Welcome to the Everything Surgery podcast. Today we delve in the management of malignant ascites. Malignant ascites describes the unusual buildup of fluid in the peritoneal cavity as a result of cancer. This condition signals advanced disease, and is most often linked with cancers of the ovary, breast, colon and rectum, pancreas, and stomach, as well as primary peritoneal mesothelioma. The underlying causes are complex and include peritoneal carcinomatosis, which increases capillary permeability, blockage of the lymphatic system, and portal hypertension, which commonly results from cancer spreading to the liver. Sadly, the outlook for individuals with malignant ascites is often poor, with median survival times ranging from only a few weeks to a few months. The approach to treatment is shaped by the patient's symptoms, their overall health and performance status, and their goals, whether aiming for comfort or prolongation of life. In most cases, therapy is palliative, focusing on easing symptoms such as abdominal swelling, pain, shortness of breath, and a feeling of fullness after eating small amounts. In this episode, we will discuss the management of malignant ascites, organized by the different treatment strategies. First, conservative and supportive measures. Sodium restriction. A diet low in sodium, typically less than 2 grams per day, can help slow down the buildup of fluid. However, it is worth noting that this is less effective in malignant ascites compared to ascites caused by liver cirrhosis. Diuretics. These medications are not always effective in malignant ascites, but they may provide benefit when there is evidence of portal hypertension, such as large liver metastases, and signs of salt and water retention, including elevated urine sodium. Regimen. Spironolactone is often the first choice, and may be combined with furosemide. If there is no improvement within a week, these medications are tapered down or stopped. Second, symptomatic drainage procedures. Immediate relief of symptoms is usually achieved through drainage procedures. Therapeutic paracentesis. Indication. This is the first line intervention when there is tense ascites causing discomfort. Procedure. A catheter is inserted into the peritoneal cavity to remove large volumes of fluid, sometimes several liters at a time. Benefits. This procedure provides rapid relief of symptoms. Risks and limitations. Habitual drainage. The fluid commonly returns within 1 to 4 weeks, so patients often require repeated hospital visits. Protein depletion. Repeated large volume drainage can lead to loss of protein, which may worsen malnutrition and muscle wasting. Complications. Rarely, there may be infection, injury to the bowel, or low blood pressure. Third, interventional procedures for long-term management for patients who need frequent paracentesis. Long-term options are considered. Indwelling peritoneal catheters. Concept. A tunneled catheter is placed in the peritoneal cavity, allowing patients, caregivers, or visiting healthcare providers to drain fluid at home as needed. Advantages. This approach reduces the need for repeated hospital trips. It enables intermittent and controlled drainage, which may help prevent low blood pressure and protein loss that can occur with large volume drainage. Quality of life is often improved. Disadvantages and risks. These include infection of the peritoneum or skin, catheter blockage, and in rare cases, spread of tumor cells along the catheter tract. Peritoneal venous shunt. Concept. This is a surgically placed tube that moves acidic fluid from the abdomen into a central vein, such as the superior vena cava, through the jugular vein. Advantages. This system allows the body to reabsorb both fluid and protein, and can be useful in patients who do not respond to other treatments. Disadvantages. High complication rate. Complications include blood clotting disorders, shunt blockage, fluid overload in the lungs, and air entering the bloodstream. Tumor dissemination. There is a theoretical risk of spreading cancer cells into the bloodstream. Because of these risks and the availability of indwelling catheters, peritoneal venous shunts are rarely used today. Fourth, systemic and regional anti-cancer therapy. Addressing the underlying cancer remains the most effective approach for long-term control of ascites. Systemic chemotherapy or hormonal therapy. If the tumor is sensitive to chemotherapy, as seen in ovarian cancer, lymphoma, small cell lung cancer, or breast cancer, effective systemic therapy can shrink the tumor and reduce fluid production. Intraperitoneal chemotherapy. This involves administering chemotherapy directly into the peritoneal cavity. Indication. This approach is mainly used in ovarian cancer, as it allows a high concentration of the drug to be delivered locally. Challenges. This method is difficult if the fluid is separated into compartments, as the medication may not spread evenly. Intraperitoneal immunotherapy. One example is catumaximab, a bispecific antibody that targets EpCAM and CD3. This agent brings together tumor cells and T cells, enhancing the immune response against tumor cells in the peritoneum. However, its availability varies by region. Fifth, emerging and targeted therapies. With the growing understanding of the molecular mechanisms that drive ascites formation, such as vascular endothelial growth factor, targeted treatments are being investigated. Anti-angiogenic agents. Bevacizumab. This antibody targets vascular endothelial growth factor, which increases capillary permeability. By blocking this factor, bevacizumab can reduce fluid production. It is often given systemically, such as in ovarian or colon cancer, and plays a role in controlling ascites. Intraperitoneal trastuzumab. This therapy is considered for cancers with peritoneal spread that are positive for human epidermal growth factor receptor 2. Summary of clinical decision-making. 1. Assess the patient. Consider whether the patient is experiencing symptoms, evaluate their performance status, and determine if they are a candidate for further cancer treatment. 2. Initial management. Perform therapeutic paracentesis for immediate relief. Fluid may be sent for cytological examination to confirm diagnosis, although this is not always necessary if the underlying malignancy is already established. 3. Trial of diuretics. Consider this step if the patient has liver dysfunction or evidence of portal hypertension. 4. If fluid reaccumulates quickly. 5. Good performance status or ongoing cancer treatment. Optimize systemic therapy and consider clinical trials, including targeted therapies or intraperitoneal treatment. 6. Poor performance status or focus on palliation. Use an indwelling peritoneal catheter to enable home drainage, aiming to maintain the patient's comfort and quality of life. Conclusion. The best approach to managing malignant ascites is to address the underlying cancer. However, when this is not possible, the focus shifts to symptom control. For patients who need frequent drainage, indwelling catheters are now preferred due to their convenience and efficacy in a palliative setting. Thank you for joining us. If you found this episode helpful, please like, share, and subscribe. This is the Everything Surgery Podcast, where we dissect the extraordinary.